Good morning, everyone, and welcome to this session on Let's Talk About the Menopause, which is rescheduled from our Health and Wellbeing Conference in October. I'm Kath from the Charity for Civil Servants. We're delighted to welcome Audrey from the Cross Government Menopause Network and Professor Dame Lesley Regan as well. Just before we start, a very quick couple of words about the charity. So we are the charity for you. We are the charity for civil servants who are working as civil servants now, who may leave the civil service at any time, or who may be retired. We help with a whole range of things around money, caring, mental health and well-being. So please do remember to come to us if you need to. But I'm not going to waste any more time because we've got such a great session ahead of us. So I'm now going to hand you over to Audrey, who will introduce Dame Lesley to you.
Thanks, Kath, and thank you to everybody at the Charity for Civil Servants for hosting this event for us. As Kath mentioned, rescheduled from the conference in October when Professor Lesley was taken unwell, but we're delighted and over the moon to have you with us today, Lesley. And for those of you who don't know, we are incredibly lucky to have Professor Dame Lesley Regan with us today. She is a Professor of Obstetrics and Gynecology at Imperial College at St Mary's campus, and she's also the Chair of the Wellbeing of Women, and she's held that role since 2020. She is also a globally recognised authority in women's health, having been President of the Royal College of Obstetricians and Gynecologists, and Honorary Secretary of the International Federation of Gynecologists and Obstetricians. And in June 2022, Dame Lesley became the first ever Women's Health Ambassador for England. So we are absolutely overjoyed to have you with us today, Lesley, and delighted to see you fighting fit again. If you want to ask questions, I think Sherry's put some comments into the chat, but it would be great if you could start your question with the topic in capital letters. So whether it's HRT or perimenopause or whatever your question might be, if you could start it with the wording, and then that will help us to bucket questions into a theme so we can put them to Lesley and hopefully get as many of your questions answered as possible. I would say that only share or ask or make comments in the chat that you're happy to put on your living room wall. I tend to use that with my children at home with social media. So if you feel content, please remember this session is not just being attended by those currently on the call, but it will be available to be watched afterwards. So yes, be aware of that. And as ever, if any of the topics trigger you or you feel you need support following this call, please remember to defer to your local EAP or wellbeing groups within your local department who will direct you to support that may be needed. I think that's everything I need to say for now, and I am delighted to hand over to you, Lesley.
Well, thank you, Audrey, and thank you to Kath as well, and to all of you for turning up over your lunch break. Which is really very, very good of you. I'm looking for my slides here. Why aren't they coming up? They should be on my desktop. Hang on. So I'm going to talk a little bit about women's health in general, and then I'm going to focus on the menopause because I think that's what you want to hear. But I'm up for being asked about anything that you want to talk about in terms of women's health, or anything I think I'm going to be able to answer for you. So let me start by telling you a little bit about my background. I'm an obstetrician and gynecologist, and I want to, I'm particularly interested. Can you see that? Yes, you can, I think. I hope so. I'm going to give you a little bit of progress on this women's health strategy. And the reason I want to do that is just to remind you, can you see that now?
Yes, we can see that. That's great. Thank you.
Thank you so much. I want to just remind you about how important women are in society. This is my most favourite Chinese proverb, women hold up the sky. But as you'll see from those numbers, women do far, far more than just half the sky. So we are 51% of the population. We're now 49% of the paid workforce. We're 68%, so more than 2/3 of unpaid caring roles are taken by women. And I think the point that I would really like to make, and I don't know if we've got any gentlemen on the call, but when we get things right for women, we get it right for everybody, because women make 80% of all household health decisions. So they are pivotal in this. That is, I believe, I've had many years, and that is that when we get it right for women, everybody benefits. And that's why I think it's so fundamental that we optimize their health. Now, you'll be aware of the fact that the Women's Health Ambassador was appointed to implement this women's health strategy, and I'll come on to that in a moment. But this isn't the first of women's health influential reports, and these are just 3 reports, but they span 15 years now that I've been intimately involved with. And they've all said the same thing. We've got to think about women's health right across their life course, not just think about a condition or a diagnosis, but think about how their health impacts each decade of their life. So the healthier you are as a young girl, as an adolescent, that has an impact on your 20s and in your 30s, so on and so on. And then for anyone who thinks, oh, well, I'm in frightfully bad health and they're as anxious as I am now, it's never too late to start to make things a bit better. So these are, as I say, the 3 groups of 3 publications that I was involved in. This second one, the annual report of the Chief Medical Officer, was called The Health of the 51% Women. And that was when Dame Sally Davis was the first and only female Chief Medical Officer. And she sort of grabbed me and said, we're going to say something a bit controversial. And it was a great report. It was about all the missed opportunities that you have, I have as a clinician, all the missed opportunities throughout a woman's life that we have to help her understand what she needs to do to help herself. And I think that's probably my most important message, is that over 40 years I've been practicing as a gynecologist and obstetrician. And at that time, my observation about women is that when you advise them what they should be doing about their health, not only do they usually follow the advice, but they don't keep it to themselves. They tell everybody else about it. And as you saw from that previous slide as well, they are also the custodians of healthcare decisions at home. So they make 80% of all household decisions. Now, just before I move on from this slide, if any of you like to go online and look at this Better for Women report, it was a report that I wrote at the end of my presidency of the RCOG, and published it in the House of Commons at the end of 2019, or just before Christmas. And I sort of naively thought that I was going to demit office from being president, and then I would then spend the next 5 years of my life sort of drifting into semi-retirement and implementing all of the recommendations from this report. But I just want to say before I move on that the first and the fundamental recommendation for Better for Women report back in 2019 is we must have a women's health strategy run by the NHS. It's taken a while to get that to happen, but I'm just wanting to look at this chart here. This is, and please don't worry about the numbers on it and the dense thing. I'm not going to go through it and get you to look at the slide for much longer. But I just want to emphasize that this is about what the problems are that women face in our country, one of the few places in the world that has a health service that is free at the point of delivery and funded by taxpayers. It's in 2025. And often when I use this slide, and I usually emphasize, even for today, I emphasize menopause symptoms and some of these things down here. But when I use this slide, there's always somebody in the audience that says to me, oh, what country are you talking about? Because they assume it's the global south, because the outcomes seem to be so simple and so poor. And the next thing they ask me is, oh, I think you've got a typo in your title. You must mean 1995. And I don't. I mean 2025. So let's have a look at this, some of these menopause symptoms, which is what I think many of you wanted to talk about, but I'm happy to talk about any of the other issues as well at question time. So the thing I want to emphasize to everybody is that menopause is an inevitable event. So any human being that menstruates, has periods, is going to become menopausal. And some women become menopausal earlier than others, and they need particular care because that puts them at risk of all sorts of other problems. Let's go to the majority. So this year, 2025, 400,000 or more women are going to enter the menopause. And my big concern is that about 395,000 of them won't know what the hell's hit them because they haven't been prepared for it. They haven't got a lot of information about it. Until very recently, this has been a taboo subject. You know, the end, you know, maternity we always talked about, but menstrual health and menopause were things that we didn't talk about. And it's a very important issue because how you end your menopause and your general state of health then, and the advice you get about what you can do to help you in later life is really, really crucial. I'm going to emphasize why that is in a moment. So some women will say that their symptoms, which can be very debilitating, last for 7 years. Others will say that they have very, very severe symptoms. They can't work. I mean, indeed, one of the factors I think that has really caught our Chancellor, and I'm being apolitical here, successive Chancellors over the last few years, has been the fact that in between the ages of 45 and 65 leave the workplace because of their menopause symptoms or because they haven't got employment that can adapt to their symptoms and cater for them and their different physical or mental health needs. You lose an enormous amount of money from the economy. But what I hope that you're going to go away after our discussion to realise is that's just the tip of the iceberg, that there are all sorts of other things in women's health that we really can't afford to let carry on. And sometimes when I'm talking to NHS England or the Department of Health, I say, well, if we can't cope with the whole 65 million population, of which 1% are women, let's just think about what we need to do in our NHS, because 1 in 5 of the whole of the NHS workforce, which is the largest in people after the Chinese People's Army in the world, are menopausal women. And that's a lot of women that we need to look after optimally. Now, I said there were some other things I wanted to talk about, which are intimately, literally related to the menopause. One is urinary incontinence. So even if you live in a home where you're happy talking about your periods and your perimenopause or your menopause at the dinner table, I don't suppose there are many women over the age of 60 who say, oh my goodness, do you know what happened to me today? I was in Tesco's, I was in Lidl, and someone bumped into me with their trolley and my bladder was a bit full and I leaked. It was so embarrassing. So 1 in 3 women over the age of 60 have a degree of urinary incontinence, some sort of leakage, and nobody ever talks about it. So that's going to be my next passion, got to sort out about pelvic health. And because there's so much we can do about it throughout a woman and a girl and woman's life to improve that, make sure that she doesn't become debilitated by her urinary leakage, and it doesn't make her into a recluse because she ends up not going out because she can't work where the toilets are going to be, and then after that she becomes a bit depressed, and then the whole thing is a downward spiral. And then I also want to talk to you a little bit about cardiovascular disease, because cardiovascular disease is one of the commonest reasons why women in this country will die. So I see there are about 70 people on this call, and 52% of the women on this call today are going to die of heart disease. And yet most women think that they get some kind of cancer, usually breast cancer. And I'd like to come and perhaps talk about that from a personal point of view, because I've had breast cancer and I'm still making sure that I have my treatment that I find particularly helpful, irrespective of that. And I'm going to explain all of that, if I may, or share that with you, because I think sometimes personal reflection often really helps. Now, why do I say that the disease often presents differently in women, and why do they receive their diagnosis later than men? I think this infographic says it very nicely. And this is one of the British Heart Foundation's infographics, which they've given me. So there are 3.6 million women in the UK who are living with heart or other circulatory diseases. And what we know is that women are 50% more likely than men to be given the wrong initial diagnosis after a heart attack. We'll come on to why that is in a moment. So that means that over a 10-year period, there's sort of like 8,500 women in England and Wales who could have survived their heart attacks if they had received the same quality of treatment as men. Not better treatment, just the same. And we know, therefore, that coronary heart disease kills more than twice as many women in the UK as breast cancer. And I think that's a really important point for us to understand. And the other big, of course, is osteoporosis and frailty. Now, these aren't particularly sexy topics, are osteoporosis and people falling over, but they're major causes of morbidity and mortality. So 50% of the deaths among women this year are going to be from heart disease, and about 40% are going to be the complications of thinning bones and becoming frail. And you'll see why that is so important, because osteoporosis, or bones that are thinned to the point of being brittle and will snap very easily if you have a fall or some form of injury, 21% of women, that's 1 in 5 women, are going to get osteoporosis versus only 6% in men. And you can read all the other figures on this slide. And there are 500,000 fragility fractures every year in the UK, mostly to women, and yet only about half of our population of women and men who have fractures have access to fracture days and services. And I would say as well that although having a fragility fracture is a red flag for someone having thin bones, we shouldn't be waiting until they have those 500,000 fractures, because then they've already got an increased mortality and morbidity. We should be thinking about making sure that every 45-year-old woman knows that she's going to be at risk of thin bones as she grows older and as her estrogen supply winds down, and give her the advice she needs to try to prevent that happening. And it's not difficult stuff. This is not rocket science. It's very, very simple. And then the other big killer of women is dementia. And we know that it's more prevalent among women and men, not just because they live longer, but because it's more prevalent and they wait longer to receive a diagnosis, just like the heart disease, and they present differently as well. So if you think about some of the people in your world or in your life, or the people you care about, may have had a diagnosis of Parkinson's, for example, women, the dominant symptom is usually upper body tremor. So it's usually tremor of their head or hands or their upper body, whereas men usually present with Parkinson's disease with balance or posture problems. So the typical one is the man who comes up to you and has got his mother stooped over and has got a sort of shuffling gait. So they present different. And this is my most important slide, and this comes from the Better for Women report that I told you about earlier. And this is basically showing what happens if you look at life as a life course approach as a healthcare professional, and as a woman, because I want women to be as educated as the healthcare professionals if we're going to really change the dial on women's health and close the gender health gap. And this is age in years across the bottom axis. And please note, it finishes at 60. And I think that's a really interesting reflection I have, because when I came out of medical school, which is a very long time ago, 40 plus years ago, women disappeared from view at 50 because they were menopausal. And they became menopausal and they were post-reproductive. So that was it. That was their moment. And yet we know that all the other things I've been talking about in the last 4 or 5 minutes, the cardiovascular disease and the osteoporosis and the bone poor health and the dementia, they're all things that tend to happen later. But most importantly, looking at this slide, what are the really important things across a woman's life course? They're all predictable. Menstrual health, well, the average age of menarche now in this country is 10. So as we've been healthier, better nourished, more prosperous, the age of menarche or first periods has gone down. It's now 10 years of age. And then, of course, as you develop menstrual periods on a regular basis, then you have developing your fertility. And whatever your feelings are about this, and contraception and sex and underage sex, whatever, the bottom line is, I want my daughters to be totally in control of if and when, how many times and with whom they become pregnant in the future. And I suspect there are very few women on this platform to feel similarly. We want the people we care about, the women we care about in our lives, to have autonomy over what happens to them. Remember that always used to be thought of as reproductive, but look, this is pregnancy care now. 4 out of 5 women have children. This country, 1/5 don't, either because they're able to or because they've chosen not to. But this is not universal now. So we've also got to think about providing care for the women who haven't gone through pregnancy and had that productive experience. And then, as I said, there is an inevitability about women becoming menopausal. So let's try to make sure that we live in a country and the world, hopefully eventually, where women don't crash into the menopause and think what on earth's happening, ruin their relationship, they can't go to work. It's awful. And let's focus then instead on those latter years. And before I move away from that slide, I just want to emphasize again how much our society has changed. So as I said, when I came out of medical school in the 1980s, women disappeared here, and they didn't live much past 65, possibly 70 if they had longevity in their family. But now, my 33-year-old daughters, they have an actuarial lifespan of 100 years. And that means that my daughters are one of the first generation of women who are going to live longer post-reproductive than they were reproductive. And I don't think we have enough understanding of what that means in terms of promoting health in our 40s and 50s so that we can have the best possible life for as long as possible. And as to a few politicians, there's been quite a churn, you will recall, in the last 3.5 years since I've been the Women's Health Ambassador. We had 7 secretaries of state for health during the first year or two. And the current government has been relatively stable, which is to be welcomed, I think, in terms of, I'm apolitical, but it's nice to not have to keep having changes of the ministerial group. Remember that it really is important to think about, I often say to them, I'm not planning to live forever, but I do want to live as well as I can, as long as I can. So I want to, in this latter part of women's lives, I want to postpone all these things that we can mitigate, we can postpone. I want to postpone them right till the very end so that we don't have, we have the maximum time in good health. And so I'm going to move on now. So this is the Women's Health Strategy. It was published in the summer of 2022, and it set out a 10-year plan. We've got another 10-year plan now, but this one started in 22, to boost health outcomes and also, very importantly, to listen to women. And that was one of the scary things. 100,000 women submitted responses to the public consultation that the Department of Health and Social Care put out. And 80-something percent, 84% I think it was, of those women said that they hadn't been listened to or they'd been ignored. I think that was something that really, really hit home to the government at the time and to the civil service. So these were the, sorry, this has gone tipping over, I've got a fast finger. So these were the 7 priority areas, and to support what I've been saying and the title of this talk, this group together, menstrual health and gynecological conditions are right at the top. So not the things that often happen when you're doing a strategy about health in the future, but these are the common, mundane, day-to-day things that women have to deal with all the time. Remember, there is nothing else that happens to a human being quite so commonly as having 12 periods a year for 40 years of your life, because you're no longer spending many, many years being pregnant these days. So it really is important that if those periods, that menstrual health is poor or disabling, it's really going to have a very, very massive impact on that woman's health. And then you can see all of the other things that are just as important, but I'm going to focus for today on menstrual health and menopause, because I think they're 2 ends of a spectrum. And if we can understand the first, the menstrual health, then the menopause won't be a shock, and it'll be a much easier transition, and women will have a much better longevity and quality of life. So these were the year 1 priorities, and don't worry, I'm going to go into great detail here. We wanted to set up women's health hubs, by which I mean a concept, not necessarily a place-based, but a concept where we wrap services around women. We also wanted to do quite a lot of work in the workplace, and I think that's one of the topics that we're going to address here and possibly in your questions. And I really wanted to improve access to hormone replacement therapy. So we've managed to achieve some of those, and there were a lot of other things too. But the topic for today is the menopause and that work. So in that first year, as I said, we tried to focus on building up ways in which we were going to improve access to services, because we thought the essential services, as I've just been saying, problems, contraception, the menopause, and we tried to build networks in order to deliver that. And I wanted to emphasize again that the hubs don't have to be a place. they can be virtual ones, and there's some fantastic examples of areas which used to have very, very high referral rates into secondary care, but by having senior people triaging the referrals, you can then signpost women to the right place. So, for example, if Audrey comes to me and she says she's got a bit of postmenopausal bleeding, there is no point me sending her to secondary care for ultrasound and blood tests and things, because we know she's going to have to go to a hub and spoke model where we can do a hysteroscopy, because we know that 2025 gold standard of care for a woman who has postmenopausal bleeding is to sample the womb lining, the endometrium. So there's no point of waiting for months and months to get the scan and the blood test and the consultation, because we know that's what she's going to need. And then there are one-stop shops. You know, my hope is that in the future, the women that you and I know will be able to go and have their menstrual period problems and their contraception and their smear and their mammogram and everything else sorted out in the one visit. Not take 5 days off work in order to do that, just go in the one visit. And then, of course, in some of the marginalised groups, particularly in the northwest and the southwest that I visited recently, they've got fantastic mobile pop-up models where a caravan, it can be loaded up with things and go touring around stations, areas where there are drug addicts or sex workers, or where people are homeless, are in fantastically popular. And really, some of those women are accessing things that they've never been able to access before, like hormone replacement therapy they've never been able to get before. So to summarise, dramatically summarise, ignore everything on the left-hand side. So when you set up health hubs and you try and have wraparound care, not make the women run around the different places, you improve access. That's not difficult to realise. You reduce inequalities, enormous health system efficiencies. But what I hadn't realised when we started off the health hub model was quite how valuable the model would be in terms of workforce retention and as a training resource. Because, you know, surprise, surprise, healthcare professionals quite like working in places where they attitude, yes, we can do that. Not, no, we can't do that, because we're not commissioned for that, or we're not allowed to do that. So that's really important. So I hope that what we will be seeing over the next few years, as we now, I'm not going to call them so much women's health hubs, but they went through a period of being to a community. Now I think we're going to be talking about neighbourhood health hubs, but there are going to be a whole load of the things that I've just been saying earlier to you on maintenance for women, not rocket science, just maintenance, day-to-day stuff that they're going to be able to access in these women's health hubs closer to home. So contraception and any form of long-acting reversible contraceptive provision, which, remember, we often use for menstrual health management when you've got painful heavy periods and problems like that. There's no reason why you should go to secondary care to get cervical screening or even treatment for that. And it's really awful when you see elderly ladies coming up, having come in an ambulance with carers, possibly the second or the third appointment to have their ring pessary or their incontinence advice sorted out, or their ring pessary changed. And as I said, you know, 400,000 every year are going to become menopausal. So let's assess them and give them treatment or advice about how to change their lifestyles or whatever closer to home, rather than make them sit on a waiting list for a long time. Now, I'm trying to just to produce a bit of sort of fun into this. The year two, at the end of year two of this was last year, I think things started to change, and I'd often like to ask myself, so why has that happened? And I think there were three things that I thought had happened. First of all, we had the benefit of 3 or 4 really myth-busting reports being published, and then there was some key collaboration forged, and of course we did then have different new political leadership. So I think the demystifying or the debunking of previous myths is really important. And I think these are the ones that the McKinsey reports really showed up, that, you know, women live longer than men, so they are healthier. No, that is not true. They live much longer, they live much longer intervals in poor health. And that women's health gap was assumed to be concentrated at the end of life. But as I'm going to show you in just a moment, it's not. It was presumed because that's where the men's health gap is, right at the end. But it's not for women. And women's health is just sexual reproductive health. Well, you know, apart from the menopause, we've been talking about non-reproductive health, haven't we? Cardiovascular and osteoporosis, which affects women particularly. in their menopausal years. And then the one I thought was most outrageous was that when you talk to pharma or industry, or even they will say, well, we don't invest in women's health because it's a niche market opportunity. And I have to ask you, how can 51% of the population possibly be described as niche? I don't think that's possible. So this is a McKinsey report, and it was real blockbuster stuff. They came to the Davos Global Economic Forum in January 24, and they said, if we close the women's health gap, we could save $1 trillion every year. And I reckon that we may not be able to persuade the UK government to be concerned about the whole world, but we might be able to get them interested in what's happening in the UK. More of it in a moment. So what are the underlying reasons for this women's health gap? Well, very limited understanding quite recently about the sex-based differences of treatments and also prevalence of disorders, as I've mentioned to you, and big data gaps resulting in women's health burden never being counted. So, for example, 80% of women treated for the menopause in the US were not documented in a year span, which was not very long ago. And then constrained access. Women have a uptake of many types of procedure and interventions than men. I'll show you that in a moment. And then, referring back to my point of earlier, low investment limiting the scale of innovation. So about 1% of all global healthcare research is invested in female-specific conditions, apart from cancer care. So there's always a lot of interest in funding in cancer care because, of course, it has very expensive drugs and treatments, but industry doesn't focus on female-specific things. Now, you may be surprised by my comment about women having a lower uptake of intervention, but I find it really difficult to understand this figure. Why is it that men are 3 times more likely to receive cardiac resynchronization therapy if they present with an arrhythmia? Very common in 50 and 60-year-olds, men and women. And why is it that 28% of men, or they've got a 8% higher likelihood to undergo a hip or a knee arthroplasty compared to women? So there's all sorts of, conclusions you could come to why that might be, but I think it could be because most cardiologists and most orthopedic surgeons are men. And then this is the one I love most. Bear with me for just a second. An asset is a molecule or a substance, a chemical, shall we say, that's already been identified in a clinical trial that may be useful to explore further. And if we look at the data globally, we know that 1 in 10 women have got endometriosis, a problem of painful and heavy periods. And there are about 20 of these molecules currently in the pipeline trying to be resourced and researched and to see whether they'd be helpful. And if you compare that to diabetes, so 1 in 10, exactly the same prevalence of adults globally has got diabetes, and there are 580 assets at this moment in time in the pipeline, because this is seen to be a really easy thing to sort out, and it will make companies and drug companies and tech companies, fortunes. And then if we look at the total global women's health burden, the things that I've been talking about as a gynecologist are only a tiny amount of the problem. That's only 5%. And then there's another 4% of conditions that affect women differently. And I just gave you some examples about dementia and osteoporosis, and we could mention thyroid disease and things like that, and cardiovascular disease particularly. And then a very large chunk of conditions that affect women disproportionately. So don't have many men having migraines or thyroid disease or rheumatoid arthritis. It's mostly females. And then there's 43% of conditions currently at this moment in time. This is data going back to 2019, where there's no current evidence. But interestingly, when you drill down into that 43%, it's not that there is no evidence, it's just that no one's actually looked at it. So this may become even more of a stark contrast. So I think that things started to change. Well, we managed to get Sue Mann, who's a gynecological colleague of mine, an excellent clinician and very, very well versed now at implementing change, appointed as the first ever national clinical director at NHS England. And we did some really important partnerships, because I think that's a really important that we use the charitable and the VCSE sector there was a new political leadership, and I think I also had a bit of a wake-up call towards the end of the second year, thinking, actually, we've got to stop writing reports and admiring the problem. We've just got to get on and change things. So here are the change makers in the women's health and general health view, arena moment. And I just mentioned partnering with charities. So as Audrey said in her introduction, I'm the chair of Wellbeing of Women, and we set up a menopause workplace pledge, which, if I'm honest, I didn't think, I thought the chief executive was wrong when she said, oh, we're going to get people to sign up to be really menopause friendly in the workplace. And all we had to do was recognise that the idea that women might need support, to talk openly about it, and to actively inform and support their employees. And we asked them to sign up to the menopause workplace pledge. It didn't cost them any money. They got a certificate if they wanted, or whatever. But now I think it's nearly 4,000 employers, including the civil service, NHS England, the BBC, Tesco, Royal Mail, to name but a few, have all signed up. And it's making a difference. Even if it's not perfect, it's making a difference because we are talking about the problems. We've also done a massive push on period problems. And if you were to scan this QR code onto your phone now, it will lead you onto the Wellbeing of Women website, and it will take you to the period symptom checker, and it will ask you about 14 or 15 different questions. And at the end of those questions, the little thing on the screen will say, would you like to receive a letter with your problems all summarised that you can give to your healthcare professional? If so, put in your email. And if you put in your email, then 5 minutes later you get a letter that you can take to your healthcare professional summarising it. So you can imagine, I'm trying to get Wellbeing of Women now to change the title of these QR codes and do it for perhaps memory leakage, menopause issues, all sorts of other things, that we could do that so well. Well, all of you, because you're all in the civil service, about our strategic priorities now, how we've got to shift care into the community, we've got ongoing waiting lists, move from treatment to prevention, and move from analogue to digital. So we know all that, don't we? But I just want to share with this why it's so important that we tackle this, and we tackle this with you working in civil service, because this is the UK data. So this is the McKinsey data reanalyzed just for women in the UK. And that shows that women live 19% more of their lives with disability compared to men. And they are saying, we have to count women, which may sound very simple, but we don't often count women. We've got to study women, because many of our trials of drugs, particularly for high blood pressure and other forms of heart disease and dementia, have all been trialled in men. And we've got to actually care for women and effectively implement those things. And we've got to invest in them, by which I mean research and as well as clinical access. And of course, we've got to include them all. And I think it's very, very important for us all to remember that there's this marvellous thing about, some people are so difficult to reach. Well, I don't think anyone's difficult to reach, but I think some women are easier to ignore than others. But here, I think, is the most important for all to understand, and that it's more than half of the women's health gap affects women during their working years. So it's really, really important that we get the women between the ages of 20 and 60 back into the workplace and functioning. And those problems are things that are quite simple to sort out. They are menstrual problems or early menopause problems, but you'll see this is a massive, massive, massive input, rather wasted resource that we're losing socioeconomically. And so it finalises by saying, thank you to McKinsey, that if we were to close this gender health gap with fewer health conditions, fewer early deaths, increase in productivity, and expanded participation, and you see these two are much larger collectively than the others, we would save 36 billion sterling every single year. And that, I hope you're going to tell me, is at least 20%, if not more, of the whole NHS budget. So if we lined up all the women, just in my field, waiting for gynecology, in a line between here and Exeter, well, rather in a line, they would span from here to Exeter. Hang on, I've lost my slide there. Where did that go? And having been to Exeter very recently, that's a very long way. Can you still see my slides or not?
Yes, we can.
Okay, well, fine. I can't see them at the moment, but never mind. I know what they say. So, so that's a really important thing. So we've got to change that, and we're not going to change this by just tweaking a little bit around the edges. We're only going to change that if we really, really change the way in which we work, and that means that we're going to really think about care nearer to home, because 85% of the 600,000 women on our waiting list today are never going to need any form of invasive procedure or operation or whatever. So you have to ask me, please, why on earth are they on the waiting list if they don't need any of these things that you usually get in secondary care? So I'm going to finish. I'm going to finish now by just saying I hope that I've convinced you that it really, really is important to move from this disease-based model into community diagnostics and community prevention and self-management, because that's the way we're going to do it. And I've just, as a tipping my hat to some people in the world who are also trying to make women's health better. And this, of course, is Atul Gawande in his marvelous book, Better. And he always says, you know, better's possible. It doesn't genius, but it does take diligence and clarity and ingenuity. But most importantly, it takes the willingness to try to do some things different. I think that's a really important learning point for all of us. So I think it's absolutely crucial that we implement the women's health strategy. Today we're talking about menopause and back to later life, but we could talk about any aspect of women's health at any life course stage. Because when we get it better for women, we get it better for everybody. And of course, I think the other really compelling argument is that we can get it better for less money. So instead of spending all that money doing things to people that are going to just clog up our secondary care, what we need to do is to put all that money into the latter years of life. Those extra years we're all going to spend in poor health unless we do something about this. So can I finish there? And I'm very happy to answer questions as long as I can do.
Oh, thank you so much, Lesley. Amazing presentation, and amazing to see the women's health strategy across the piece rather than it just be us looking at menopause in isolation. Have we still got you on the call? Or have you? Oh, how's Lesley? Is Lesley still with us?
I can't see, I'm just scrolling through the participants at the moment, Audrey, but at the moment,
I wonder if she's dropped off.
She's dropped out. Oh, here she is. Oh, no, that's just somebody saying, are you there?
I wonder if she's dropped out by accident. Let's see if she comes back in.
Oh, here she is.
Back again, Audrey. I'm back again.
Welcome back.
Thank you.
Thank you very much. Thank you very much for that. I think it paints a really stark picture, and I don't know about everybody else on the call, but it felt like we were looking like years ago when it comes to women's health and women being second-class health patients, if you like.
And I think that's what we've got to change, Audrey. It's not an afterthought. It's not because I'm a fucking drum or anything. It's because this is just, we can't afford to carry on like this. We contribute far too much to ever have very simple things not looked after well, because it's very simple to do, and then we can plough all that energy and wasted resource into the things that we really do need to research going forward, so that you and I will have hopefully a relatively good quality of life up until the last few years, not a very long period in poor health.
Yeah. And do you think it's a training problem with the medical profession?
I think it's multifactorial. I think it's definitely a training problem, and we've got to have a different emphasis. I mean, it's interesting. One of the first reports I was ever involved in women's health goes back a long, long way, and it was called. It was basically something 15 years ago that said, look, as we become more and more specialist, let's not forget about the basic things, and we've ignored it. It's exactly what's happened. We've become so specialist that we've forgotten about the basic things. Things like, I haven't talked about contraception. I mean, it is absolutely shocking that 45% of pregnancies in this country, the UK, are unplanned. And I'm not saying that they're all unwanted, but they're unplanned, and unplanned pregnancies have much higher complication rates. It's because women cannot access long-acting reversible contraception. And that's why the abortion rate has gone up. It's not in young women or girls, and whatever your views are about abortion. I mean, I've worked in sub-Saharan Africa where if you ban it or you make it difficult to access, girls and women die. So that's a fact of life. And if you make it difficult, but the women that I talk to, who are in their late 30s and 40s, they tell me they've come for an abortion because they've completed their families and they've been on a list waiting for a Mirena coil or an implant or something to suit them for 18 months. And then they fell pregnant during that time.
Yeah.
So we've got to do stuff. I mean, contraception is a really good example because contraception is the single most cost-effective intervention in the whole of healthcare. And every cardiologist, orthopod, every other specialty will agree it is the most incredibly effective. And yet we've done it so badly because we've allowed the commissioning for these pathways to go into silos. And if you're not responsible for the poor outcomes when you don't do your bit properly, there's not much incentive to get it right, is there?
No, there isn't. And I can see that. I can see the contraception point. I mean, I'm in Manchester, so I'm in the northwest. But I remember back in the day, the Mirena coil would be done at the GP surgery, and there is a question in the chat about that. We're seeing that this has become more centralised now. So you have to go around that hamster wheel of trying to get a referral and then wait for an appointment. And so I can see where unplanned pregnancies might come in there, but it's incredibly frustrating if you just simply want to go and have a Mirena coil fitted or changed. And do you think the women's health strategy will help to improve that? Because I kind of feel like GPs have almost abdicated responsibility in certain areas of contraception over the last few years.
Yeah, well, good observation, and you're absolutely right. I mean, when I was a junior doctor, first thing I did when I was doing my obstetric ward round was I went round the postnatal ward and made sure that every woman who was leaving that day had some form of contraception to go home with, baby in one arm and either pills or tablets or whatever. It was my responsibility to do that. I wouldn't dream of turning up the consultant ward round before I'd sorted all that out. And now everyone goes, oh, well, somewhere. And then GPs, the other concern I have, and this is why I'm talking to the GMC and to many of the colleges about training. So about 50% of GPs now don't have any exposure to obstetrics or gynecology. It used to be a compulsory part of their training, but they don't now. And I think we have to change that because 51% of the population is not going to get smaller, is it? And so we do have to have them contributing to this. And I don't think it's just primary care. I think there's lots of other things as well. So if you came to me, Audrey, because you wanted me to fit you with a Mirena coil as womb lining protection for your estrogen hormone replacement therapy, I could do that because I'm a specialist gynecologist. But if you walked in 20 years younger and said, oh, I want contraception and I really fancy having this Mirena coil because everyone says that you stop having periods and it's much better if you don't get anemic. I meant to say to you, I wouldn't, I'd cheat, but I meant to say to you, I'm sorry, I'm not commissioned to do that. And by the way, while I've got the speculum in, and you're a bit uncomfortable, as I'm hopefully giving you some local anaesthetic to put this Mirena coil in, because you shouldn't be uncomfortable. And that's something else women have got to demand. I'm not going to have a procedure unless you give me some local anaesthetic. I'm not allowed to do your cervical smear. because as I'm not a cancer doctor now or a screening doctor, I'm not meant to be able to do your smear. So you're going to have to go and see somebody else. Promise you won't, Audrey. I will be doing it anyway. But, but then I have to sign away my life saying, yes, I will take full responsibility for this, blah, blah, blah. Because, and most people give up in those situations. It just becomes too hard to fight this 20 times in the morning. So we've got to change the way we do things.
It just feels like we've gone backwards. It really does. Instead of having the one-stop healthcare. Tracy, I know you've got your hand up, but I'm going to try and go through the questions in the chat. And then if we've got time, I will come back to you. Okay, I have, just listening to your presentation, I've got about 50 different points that I want to talk about. But while we're on the national picture, HRT and the postcode lottery, I kind of feel like where you live in the country pretty much dictates what kind of care you're going to receive in terms of HRT or proactivity, which I've not got a great deal of experience in.
Absolutely, and I think that's really important, and that's something I feel very passionate about. When I go up to the North Cumbria to visit their ICB, because they've done lots of women's health hub initiatives, which is fantastic. As you know, they've got pretty disadvantaged communities there, and rarely do I go up there for more than 24 hours and not meet somebody in the street who says to me, she said, thank you so much for those prepaid certificates for the HRT. She said, because this has been the difference between me being able to access it. They had one prescription for her HRT for a whole year. And previously they were given scripts every 1 or 2 months. And it is so life-changing if you're suitable for HRT that that's just it's just a no-brainer, and we've got to change that. If I had all day to talk to you, I could show you all the slides of disadvantage, disability, and HRT is right at the top of those things for which there's a postcode lottery, right at the top. We've got to change that.
Definitely. And I think for those of you on the call who might not be aware, Leslie's referring to the HRT prepayment certificate, which is available, which you can buy for a year, which is the equivalent of, I think, 2 prescription charges. So you can buy a HRT prepayment certificate, and then all of your HRT prescriptions will be covered for a full year by using that certificate. So we will search the link for that and drop it into the chat as well. It is really important. I completely agree. And I think when you talk about women's health in general, I've got a prepayment certificate for general prescriptions because, more health problems being a female, which I hadn't realised before. So there's a question here about insulin resistance and what women can do, because there's been a lot said about insulin resistance being the root cause of many chronic conditions and diseases, including diabetes. So what could we as women do to ensure that we're insulin sensitive or reverse insulin resistance?
Lose weight.
Lose weight. Okay.
So it really is important. So one of the problems that we're having at the moment is that I think we have got a very, very altered concept of what healthy weight is. And there seems to be also a societal reluctance to talk about obesity. And I know it's uncomfortable, and I've got myself into trouble with patients in the past. It's the only time I've ever been reported to the DMC, Touchwood here, when I said to this woman, look, I can't treat you for your fertility issues because you're too overweight, you would have these side effects. And she was absolutely furious with me, and I've learned how to, deliver that same message, perhaps in a more diplomatic way now. But it really is a problem, and we have, society now believes that we can be any weight and have a pregnancy whenever we want to, and at any age and at any BMI. And we've got to do something about it, because even if you're not worried about the reproductive things, the pandemic of obesity in this country has increased the prevalence of every single cancer, including brain cancer. So it really does affect everything. And what we have to try and get women and men, everybody to understand, weight or the fat is not padding, it's an organ. It's just like your skin, it's all over your body and it's an organ. and it's producing really, really nasty inflammatory chemicals called cytokines. And that's what causes the increased risks of cancer. In younger women, it causes them to not be able to ovulate and have problems with fertility, polycystic ovaries and all that sort of thing. All sorts of problems. There is obesity increases the complications of almost every other disorder I know of.
And I think, isn't there something about fat cells store estrogen as well? Is that one of the
reason why we've got an increase in endometrial or womb cancer is because the fat cells store masses of estrogen. So it's like an unchecked extra source of it. And that's really, really important. And it's also the reason why women who are very overweight have got a much higher risk of having breast cancer. Now, what happens is that women will say to me, oh, I can't possibly take this because I've got a family history of breast cancer and I can't take HRT because of that. But they're so wrong. And as I've shared with you before, Audrey, and I'm happy to do so with the platform, I've had breast cancer several times and I'm quite slim and I've got quite thin bones. So I've been taking my HRT. And when I had my little scare, when somebody thought I'd had a stroke, I'm just telling the platform here, back in October when I let you down at short notice, I was very pleased because I got sent off for all these scans, which were all fortunately normal. But I saw that my bone density scan, which I hadn't done for 10 years, hadn't had one for 10 years, was actually I've got better bone density on my HRT than I used to have. And if you take your HRT, and if you're not able to take HRT for any reason, and it's rare, if you think about all sorts of ways in which one can deliver HRT more safely for people who have medical risk factors, but we can usually find a way of doing it if you need it or if you would like it. It really is very, very, very important that we think about all of these things. It's not just the breast cancer. I mean, that's, as I started off by saying, that's a very small number of deaths every year. It's the way that HRT can postpone, doesn't get rid of it completely, but it can postpone heart disease. It postpones osteoporosis, frailty, and there's also data accumulating to say that it can postpone dementia. So what I want to do is to live as long as I can for as well as I can for as long as I can, and postpone all those things right to the end, not spend my last 15 to 20 years disabled and dependent on other people, because being dependent on other people doesn't really suit my character.
I can't imagine it does. Marvellous. So a question on brain fog and memory. Does anything really work to help this?
Well, I quite a few things do. I think HRT does, estrogen does. And if you take HRT transdermally, so you have a patch or you use gel, and you have a Mirena coil to protect the wound lining, that's probably the safest way to not risk increases in blood clots, not have increases in breast cancer, and to maximize the benefits from heart disease and things like that. But you'll need to make sure that your weight is in an okay range before you do that. Otherwise, you're piling up your risk factors too. But brain fog, I mean, there's all sorts of things. I mean, there's something people talk about supplements here, things like iron. Well, I'm not sure that it does. Magnesium, yes, I think it is quite good for sleep. At this time of year, I'd take some zinc tablets as well, because both zinc and magnesium are quite important metals that sit as coenzymes and really do help with the immunity. So zinc and magnesium, not expensive ones from the health food shop. Go and buy the cheapos in Boots, because I promise you that the Boots branches or the local pharmacy, but they are just as effective as anything that comes in a posh bottle, and they cost a fraction of the price.
Great advice. And I, just going back to your point there about HRT, I was very struck when we spoke earlier in the year and you said you've had breast cancer several times, and woe betide anybody tries to take my HRT off me, because there is so much fear out there. And I remember my own mother-in-law being taken off HRT when that original research came out back in 2003, and because she was frightened, and it unmasked arthritis in her hands, etc., that she really wouldn't have known about if she'd have been allowed to stay on it at the time. So, and interesting
And
that you can find a way for any woman to be able to take it that wants to take it.
exactly. And it's for everybody. But I think there are many women who've been told they can't have it for completely spurious reasons. And we've got much more data now. I mean, there's also no reason why you need to stop it, because I'm always meeting GPs, oh, well, she can't take it for longer than 5 years, can she? Well, why not? If she's well, and, you know, she's got her blood pressure under control and she's not too overweight and all, there's no reason why she shouldn't continue it. And I would argue that, you know, if we look back, I look back on my career as I drift off, I think we will conclude that the worst thing that we ever did for women's health was to deny 2 decades of women HRT between 2003 and 2022.
Yeah, absolutely.
Really.
So a question on educating men and younger women in the workplace. So how can men and others who don't understand in the workplace be educated? And I think certainly within the civil service, we're trying to do a little bit more. And within the Department for Education, we have a number of Menopause for Men sessions running to try and educate men how to support partners and family members. But how do you think we can do it in line with the Women's Health Strategy?
What I say when I'm talking to a group that have got a lot of men in it, is first of all, I thank them for coming, because I think sometimes they've had to sort of put on their big boy boots to come along. And then I say, well, what you're going to be hearing about today may not affect you personally, but I think I said, I don't feel there's any men in this room who don't have girls or women in their lives whom they care about. And so I need you to understand about this, because I'm only one person and I can only talk to a certain number of people in my working year. And we need men to be our advocates as well, and we need that allyship. And when you talk to them in a way, and I think it's important to talking with them and to them, not at them, and that's just a delivery thing, isn't it, about how you go about the discussion. I think they sometimes become the biggest advocates and the greatest champions. I went to an employer's, I can't remember what it was now, was it a retail network of employers who were having their annual meeting a few weeks ago. And I was struck by the fact that apparently 90% of people or humans that work in retail are female, but the room was 50-50 men and women, because there were a lot of men in senior leadership roles. And I was really struck by, I gave them a similar sort of talk, but it was more towards, the economy and things like that. And several of the men got up in the question time and said, I've already texted my wife to say, I'm so sorry, I've never asked her about her periods, and would she like to talk about her menopause when I get home tonight, because I really do care that she's okay. And I just didn't know. And then somebody else said, well, I'm going to set up a board meeting tomorrow. And I was talking on a Thursday, and I said, oh, on a Friday, joking. He said, yes, I'm going to call them in, and we're going to have a board meeting, and we're going to make sure that women's health and post-reproductive health and the menopause are, factors on my board agenda every single month. I just didn't know about it. And you can say, well, okay, where have they been? But, everyone's busy, aren't they? I mean, I live and breathe women's health, but I can understand how some people don't.
But
yeah. I'm very struck by how men are, very important in the conversation. They are the other 49%, but most importantly, when you say it could be someone that you really care about in life, your mum, your sister, your daughter, your friend, or whatever.
Yeah.
And they're very responsive.
Yeah, it's not a joke. It's not something to laugh about. It was a taboo topic years ago, but it's becoming more and more prevalent now, and men are being brought into the conversation, and rightly so. A question about dementia. You did touch on dementia on your presentation. It's been said that that Alzheimer's is now being called in some medical circles type 3 diabetes. What's the relationship between Alzheimer's and diabetes? In terms of, I guess, and then linking it back to menopause?
Well, I think it's to do with the fact that, the older you get, the more likely you have dementia, because it's very age related. We're all living longer, and we're all living, I think, in many ways more unhealthily. So there's an obesity thing, there's a lack of looking after oneself. there's a lot of evidence as well now that shows that the risks of dementia, and of course that's a very general term, there's lots of things that fit underneath that with very specific diagnoses, but overall the risks of dementia increase when you lose contact with a workplace, or even if you've retired and you're happily retired, when you start to, if you like, switch off from the community around you. So interactions are really important. And then when you start to switch off, then you don't go out and you don't exercise as much. And all of these things all become a bit like a rolling stone that gathers moss, because you don't do the exercise, you don't go out, then you're embarrassed to go out because you've put on a lot of weight or you don't feel quite right. And then the whole thing becomes worse and worse and worse. And the net result is you have a woman who becomes almost reclusive. And that's when the dementia sets in, if it hasn't already started. I mean, of course, there are exceptions to that, of younger onset and things like that, for which we don't necessarily have answers. But basically, keeping yourself fit, keeping yourself as slim as you can do, or eat as healthily as possible, and plenty of exercise. Remember as well, there's evidence for osteoporosis and frailty that weight-bearing exercise is really important for women. So it's not cardio and running a marathon, it's weight-bearing exercise is really important, because women lose more muscle mass than men as they grow older. And let me just say to anyone who is benefiting from the GLP-1 or the obesity drugs now, remember that you lose as much muscle mass when you take those drugs, Wegovy or Ozempic or Mounjaro or the new ones coming on the market. You lose as much muscle mass as you do fat. So if you don't do weight-bearing exercise, and you don't have to have expensive kit, you can just put on your leggings at home, and you can fill up some water bottles, or you can put some casserole dish and lift it like a weight and whatever. You've lots of things you can do at home, but you've got to do some strength training and get those muscles, particularly your upper body and your quadriceps and hamstrings working. So I always say you've got to exercise the things that lift things up into the wardrobe, and you've got to exercise the muscles that get you out of the chair.
Mm-hmm.
And then you've got a problem and you need to get out that chair.
Yes, yeah. And I'm a hypnotherapist in my spare time, and I always advocate the 3 Ps: positive action, positive interaction, and positive thinking. Another question on HRT, been prescribed estrogel and progesterone tablets, but have not started it yet, as a friend asked me if it was bioidentical. This led me down a bit of a research rabbit hole, which predominantly seemed to confirm bioidentical HRT was the gold standard and preferable to synthetic HRT. Is this available on the NHS? Is it better? Because it's a minefield out there, and it's hard to know which sources of info are reputable.
Yes, okay. So transdermal HRT, estrogen gel or estrogen patches, is bioidentical. It's estradiol, which is great. By synthetic, yes, some things are synthesized as opposed to being synthetic, as opposed to being, in quotes, bioidentical, which means that it replicates the same hormones that are flowing around your ovary when you did have ovarian function left. But I think it's got a bit of a hype, and I'm afraid it's got a bit of a hype because of the private sector and the sort of tendency to sell these things in posh packages fast expense. But the reality is that Utrogestan, which is the tablets that you take every day to protect the womb lining, that is also bioidentical HRT. And if I remind everybody, 20, 30 years ago, we used to use Premarin, and Premarin and various other synthetic hormones were made from pregnant mare's urine. That's when I think that's where the bioidentical, that was non-identical, came in. But I don't know anyone who uses that anymore. And so if you're using estradiol or a trans double preparation, and also some of the tablets are fine. Some people can't use the gel; they don't absorb it. Some people find that the patches give them irritation on their skin. So the tablets are not the end of the world. but you should probably go along and speak to somebody the best form for you. But if you can use a transdermal preparation, if possible, and use a Mirena coil or a Utrogestin tablet at night, that is all bioidentical. I mean, in fact, the Mirena coil is not, strictly speaking, bioidentical, but I give it top rating because so little of it ever gets absorbed anywhere, because the womb muscle is so thick, Audrey, that, you know, it just controls the womb, stops it becoming overactive, often reduces pelvic pain. So it's very good for women who have painful heavy periods as well, and or who have had pain during their menopause years as well. But very, very little of it gets absorbed into the bloodstream and becomes systemic. So I think that's a pretty safe one. So, I mean, if I had another slide, I'd be showing a little thing of matchstick ladies. There's 20, so there are going to be 23 episodes of 23 incidences of breast cancer per 1,000 women aged between 50 and 59. And we can do the figures of slightly higher for between 60 and 69. But that's the background risk, because breast cancer is so common because it's triggered by various things in our environment and also by estrogen, and that's what women have, lots of estrogen. But if you use HRT, estrogen only, you have fewer cases of breast cancer. So the progesterone is actually a contributing factor. If you take combined HRT, you will have another 4 extra cases. So you go from 23 to 27 per 1,000. But those are not deaths, they are cases. And most women on HRT are having screening mammography and things. So those are picked up early. So these are not things that are going to kill you. And as I say often to the women I'm looking after, look, you know, when you're dead, you don't really care what killed you. It's really really important to live a while you can. And as I say, 4% of the deaths in this country this year will be breast cancer, despite the fact it's got the higher prevalence of everything else. And 52% of deaths will be due to heart disease, and 40+% will be due to the complications of osteoporosis and frailty. So you've got the data there. It's much, much more important to be protecting your heart and protecting your bones and protecting your brain and your dementia than it is to be worrying about the small but risk of breast cancer.
So HRT is great for heart health, brain health, and bone health. Okay.
Correct.
Can I just ask about testosterone? I know it's recently been licensed for women, and I think it's probably still going through the process for being approved for local GP prescriptions. How well does testosterone help women with perimenopause or menopausal symptoms?
Well, I think that's a very idiosyncratic response to testosterone. Some women swear by it and say it's fantastic. I mean, it's the licenses. So the issue now is that it is not licensed for use in women for menopausal symptoms. So it's not available at the moment on the NHS. I mean, as you say, we're going through the bureaucracy to change that. But if you came to see me, I would have to give you a private prescription, Audrey. And on the bottom, when I signed my name as private prescription, I would have to write, otherwise the pharmacist wouldn't prescribe it. This is prescribed off license in the full knowledge of the patient, understanding the potential risks she may be taking.
Mm-hmm. Okay. But I mean, I am on testosterone, and it was prescribed after my hysterectomy. And one of the things I found, because my levels went too high earlier this year and I dropped it off, was that when I stopped taking it, I found a difference in my memory. I really felt that it
Yes,
did improve memory and brain fog.
Yeah, and as I say, and other women will say, well, you know, it wasn't worth it. It didn't really help me at all. So idiosyncratic, but it's like most things, you know, women are complex organisms. So no two women are going to behave the same, whether it's their blood pressure pills or their HRT or their testosterone. So, you know, we've just got to try it and see. And that would be the other thing I would say, if you're experimenting with, not experimenting, but if you're chopping and changing and trying to find the best thing for you in terms of HRT, make sure you only change one thing at a time.
Yeah.
Because otherwise you've no idea what's making you worse or what's making you better. So it's a very simplistic point, but just if you're going to change stuff, then by all means experiment and try all sorts of different combinations, but do it one at a time so you know how you're reacting. And also give it a fair crack of the whip. Give it 3 or 4 weeks before you make any decisions about whether it is or it's no good.
And sometimes it can be just as simple as you need to up the dose, and other times it can be you need to change the preparation, because I think I've spoken to a number of women who have been in that situation. So it's not a case of, oh, that's not working, I'm not going to bother anymore. You just need to find what agrees with you and what works for you. And somebody just mentioned about testosterone. It has been licensed, hasn't it, now for women, and it's going through. Is it going through approvals? Will GPs then be able to prescribe testosterone with it being licensed?
They should be, yeah.
Marvellous. A question about those that are not office-based or neurodiverse. What are the top things that we can do to help support and recognise those impacted by menopause?
Well, understanding that, neurodiverse people are not stupid people, but they process data in a different way. So I'm not even going to say how you should process the data or present it to them, because you need to find out how they want to receive it. And I think that's really important, that you understand that we all understand that people process things in different ways. And if we want to communicate and we want to get through to as many people as possible, then we need to find the way that that woman's going to be most receptive and get the most benefit from the advice that you're trying to share. Yeah. I mean, my experience of working with the Women's Health Collective, Wellbeing of Women, we've got quite a lot of women who are neurodiverse and have got quite serious ADHD diagnoses. They're a bit like the men that you convert to talking about women's health and with the importance and the value of information. When you found a way to communicate this to them that they find helpful and they're receptive to, they become the most wonderful advocates. I can stand them up on a pillbox and they will broadcast to the nation. So they're really, really very passionate about it. And I understand that. If you've been in a minority group or you felt excluded, and then the system allows you to feel included, you want as many other people as possible to join, don't you?
Yes, of course you do. You do. Can I just ask if anybody is posting questions in the chat, that we won't be picking them up because we are picking up questions that are being posted in the Q&A. So if you could refrain from the chat, that would be really helpful, because I am trying to work through what's in the Q&A section. Question on perimenopause, ADHD and PMDD. Is the Mirena coil an option to help with regulating hormones, which is exacerbating ADHD symptoms and mood regulation? So I guess that's probably a more neurodiverse kind of general question there.
I'm not sure I know the answer to that, because once again, I would say, I think it's these very individual responses, and you have to be prepared to, if you are the person suffering from the problem, to change and try different things. But if you're prepared to do that, you will find something that you can help with. I've had women tell me that Mirena has been life-saving for their PMDD. And I've had women who've come back to me a couple of weeks later and said, you've got to take this out now, I'm going to kill myself. So, it's a very, very idiosyncratic response. What I would say, and say very firmly, is because your friend or your neighbour or your daughter or your sister said, oh my God, never have a Mirena coil, it was agony and it was awful, and I don't want to put hormones into my body. Please don't tell me that, because it fires off the red light in my head, and I start this long spiel about how important it is to do this as an individual, and that everybody's is individual. So please don't reject those things. If you've got a Mirena, it can be absolutely life-saving, and it really is such an important way to manage menstrual problems as well as manage menopause, but particularly during the menstrual years. So one of the things I often tell my trainees when I'm teaching them how to operate and that is, when I was a trainee at their stage, I would do at least half a dozen hysterectomies a week when I was working in Cambridge. They never see one now. They're fighting to see one, because we don't do apart from for cancer care and for some, some unusual cases, hysterectomies are not common procedures now because we've got so many other ways of managing menstrual problems. So it's really important to understand that and to realize that there are so many things that we can do. So, for example, I mean, if I had £1 for every politician or policymaker who told me in the last 3 years, we must do something about endometriosis, I'd be so wealthy, and I'm not. But what I do say is I get really quite on my soapbox about that too. Women do not wake up with endometriosis one morning. They develop endometriosis over quite a long period of time because their painful or their heavy periods have been neglected. So that is rather one of the reasons I keep emphasizing the importance of thinking about the life course, because if we get young girls and young women to understand about menstruation, then they understand what's normal and what they shouldn't be putting up with. I mean, I see women who have had such appalling periods that they are so anemic, and if their hemoglobin's normal, their oxygen carrying capacity is normal, their iron stores are so low that they've got the most terrible brain fog and they really can't function. They feel tired all the time. And it's because of their bleeding pattern. So that's why things like Myrena's are so valuable and so incredibly life-sparing, because this is a relatively non-intrusive thing. It's certainly not a major operation, and it can be done. It should be able to be put in anywhere in the community as well.
Okay. What should women over the age of 20 be doing to keep in optimal health throughout their lives? Is it just about nutrition and stress management?
Yeah, I think, but you'd be surprised how many 20-year-olds have got problem periods and they've been told they're normal. That's what women have.
We've dropped the link to the period symptom checker into the chat as well, so that people can, and we share that everywhere across the civil service when possible.
And I can also say that brings me back to a neurodiversity link as well. There's really good evidence now that if you get low iron stores, so if your serum ferritin level, which is an iron store measurement, if your ferritin is low, that you have a much greater increase in the risks of ADHD and anxiety and depression as well. The importance of the serum iron, which is another one of my soapbox points, because it's so easy to treat, is that it really is important for pregnant women as well, because if you're a fetus growing in the uterus and a woman's iron deficient, first of all, you will take as much iron as you possibly can from your mother's stores, number one, so she'll feel even worse. And even if she doesn't mind that happening, the other thing is that we now know that the long-term follow-up of those babies means that they have poorer cognitive development if they've been deprived of iron during the pregnancy.
So this is the whole thing for young women to be thinking about, really, what they're taking, what their blood levels are, what their iron levels and iron stores are. Not just their iron level. I think that's the thing, isn't it? It's the stores as well, and making sure that they're taking
their iron stores. And so why I think that's so important, and why I was saying about going back to the young women and making sure they understand about these things, because if you understand about periods, and the boys need to understand too, because they've all sisters and they'll have girlfriends or they'll have mums anyway, even if they haven't got the girlfriend. But the bottom line here is that if you understand about periods, then you probably understand a bit about fertility and the need for contraception. We won't then have women turning up at the age of 40 and saying, well, why didn't somebody tell me my eggs were going to run out? Which is something I hear regularly at my clinics, and they're very distressed about that. And then, of course, there is an inevitability. If you've been having periods, then you are going to become menopausal at some point, some in earlier than others. So all of those things will just become part of that life course, as opposed to being some mystery that you wake up finding yourself in trouble with. So I think it's so important. So sometimes people will say to me, well, what is the one thing you would change? And I think what I would really change is educating girls. That's a really big thing we could change. Educating girls about the importance of menstrual function, being autonomous about the control of their own fertility, and all of the things that are for them when they're older that we need to start preparing for in early life, not just start thinking about it when you've fallen over and had your first hip fracture.
Yes, yes, exactly. Okay, let's see. Oh, just on that point, there was a question there about endometriosis actually, and whether starting to take HRT can increase suffering with endometriosis.
Well, again, it's very idiosyncratic. Roughly speaking, yes, probably it does increase it, because the reason why endometriosis is painful is that you've got womb lining or endometrial cells that are not in the womb lining anymore. They've gone into the pelvis, the abdominal cavity. So it's important for everyone to understand that womb lining cells or endometrium, it doesn't have a brain of its own. What it does is it responds to the hormones it's shown. So if it's shown estrogen, which you will get either with your normal cycle or in menopausal years, if you're taking HRT, then the cells will proliferate. They will get bigger and thicker. And then when the cycle comes along and they start to disintegrate again, that's sort of, if you like, shedding, because it's not in the womb cavity, it sheds against the pelvis. And we are trained from an evolutionary point of view, our bodies are trained to recognize pain when we have bleeding inside the tummy or the abdominal cavity. And so that's what causes the pain, because if you're taking hormones, and you may, what you can do is do some very clever things now. There's some very clever new medications, like Relugolix and things like that, where you can give yourself, if you've got the endometriosis problems, you can give yourself a drug which blocks all that hormone and sort of dampens it down and places you back into a sort of a pseudo-menopausal state, which is caused by these drugs. And then when you've got control of the cycle, you add back the estrogen so you don't have the nasty side effects. So, you know, we're getting cleverer and cleverer at being able to do this. So there are things that one can do for endometriosis sufferers to provide them with the estrogen that they need to protect their hearts and their bones and their brains at a later date. But you need to go and, you know, think about trying things out for different people, and different regimens will be good for different people. So try it and see.
Yeah. Okay. I think this is a bit of a personal question. After a history of breast cancer, 2 lumpectomies, breast cancer recurrence, and double mastectomy, my question is how to cope and what options are open to me. My requests for a hysterectomy are falling on deaf ears. And that's a real advocate for yourself point, isn't it? And not taking no for an answer. But what if you are coming up against consultants that are just simply refusing to hear what you're saying? And we do hear that quite a lot, actually. Not so much consultants, more from a GP perspective, we hear it. But from a consultant point of view, would you have any advice there?
So I think the first thing to say is to write it all down so that you've got a list of things. Because I know when I go and see somebody for my healthcare that, you know, if it's something that's worrying me, then you don't always process stuff. And take someone with you, because having a second pair of ears in the room is important. I also think that sometimes repeating the thing back to the person who's saying it. So saying things like rather than getting cross and upset, saying, sorry, so you're telling me that I can't have a hysterectomy because why? Why is it that I'm not allowed to have a hysterectomy? Those sorts of things. I'm simplifying it, I know, and I know how stressing it can be when you feel you're not listening. But you know, that's why I've stuck this job out for 3.5 years, because it was all about answering those 84% of 100,000 respondents saying I was ignored when I went to talk about it. And we can't change it overnight, but we are changing things gradually. And if I asked you, Audrey, 4 years ago to come along and join me at a women's health conference, I bet you'd have said to me, well, what are you going to talk about then? But now we all have a much broader understanding of the fact that women's health is important. It's been neglected in the past, and we're all now trying to work towards bettering it for all the reasons that we've shared today, because it doesn't just benefit women, it benefits everybody.
Yes, absolutely. A question here on hysteroscopy, and it's funny because I have a colleague who's just been through this about and I've had this myself actually, hysteroscopy without a local anaesthetic. Is it recommended that it's done without or with? Because I've had both, and not the most pleasant experience without, I would say.
It's a horrible, isn't it? It's horrible. The pain is horrible. It's grinding, and it's sort of it's unlike anything else. So I feel very strongly about this, because women are told that, oh well, because you have children and things like that, you've got a high pain threshold. It's rubbish. And also, Afro-Caribbean and Black women tell me that they are often told, oh, you'll be fine because you've got a high pain threshold. This is rubbish. Nobody needs to have pain when they're going to see the gynecologist. And I think there are all sorts of things to do. So if you were coming to see me with a child and I wanted to do a blood test on that child, I would undoubtedly order the blood test, and I would also give you, as the mother, a prescription for some Emla cream or some local anaesthetic so that they weren't hurt when they had the thing. So why can't we do the same for women? I can prescribe you a tube of Instilla gel, which you can put into the vagina 5 minutes before you try to do something. And if that's not sufficient, then you can have a paracervical block, so an injection into the cervix of local anaesthetic. And then I think you've got to select the patient as well, because if you're an 80-year-old who's got an atrophic vagina and you've never been on HRT and you've never had children, it's not going to be easy getting into this uterus. So why are you going to put her into this embarrassing situation where she's got her legs up in the air and she's all in a state and she's really distressed? So that's the woman that needs to come in for a very light anaesthetic and have something done in the day's surgery. It takes 5 minutes to do, but some women are going to need to have anaesthesia, and some women are particularly sensitive to intrauterine instruments. It's usually, it's not so much grasping the cervix to steady the uterus, it's usually when they put the sound in, or actually when they actually put the coils in, or the hysteroscope in, when you touch the top of the uterus with the instrument, that seems to set off pain signals. But I would argue that you wouldn't dream of attempting to do a scrotal or a penile biopsy on a man without anesthesia. So why would you try to do it to a woman?
Yeah. Yeah, and you wouldn't do it topically either, would you? You wouldn't take a biopsy off the skin without a numbing agent of some description. So yeah, I get that. I hope that's helped answer the question. Can you recommend a website to support urinary incontinence and give advice on how we can both prevent and improve this common problem?
Yes, so I would definitely go onto the Wellbeing of Women website, Wellbeing of Women, all one word.
You'll post that in the chat as well for people so that they can access that.
And you go along to the urinary incontinence stuff. There's lots of stuff there. There's lots of apps, phone-based apps like Squeezy for helping you with pelvic floor exercises. There is a really good setup in Southeast London, in the Croydon area, where they've halved a number of women going in for urogynecology surgery by providing on phones and physiotherapy exercises and medications in the community. And of course, go along with urinary problems, about 50% of them are going to be due to urge incontinence or irritable bladders, and the other to stress incontinence, which means a structural problem or a mechanical problem. And mechanical ones are the ones that we sorted by surgery, and the others are made worse by surgery, and you need to give them physio or drugs or pelvic floor exercises. So I know pelvic floor exercises are rather boring, but they are fantastic. And as I'm sitting here, I'm going like this, do your squeezes all the time, because we all have it. We're all going to leak a bit after the age of 60. So keep on doing that and keep your exercise going. And there's lots and lots of different things. You can also go on to the what's it called, the BSUG, the British Society of Urogynecologists, and they've got lots of patient information. And you can also go on to the NHS website now. So I know it's a little bit boring, NHS website, because it's white and black and blue, but we are now allowed, because I've been prodding to post all sorts of links to other things. So if you go onto the NHS website, you often get diverted to the Wellbeing of Women, Women's Health issues. There's a whole women's health section on the NHS site now. And if you look up urinary leakage and things like that, you will find links to other things. But as I say, British Society of Urology and Gynecology, and there are all sorts of things like MASIC, you know, the pelvic floor exercises, and also OASI. So, you know, the birth trauma, obstetric anal sphincter injuries, but there are lots of patient OASI, but there are lots of patient information leaflets and excellent advice to be found there. So lots of different stuff.
And I've just dropped in the Women's Health Concern link, which is through the British Menopause Society as well. So there's another one there.
Very good. So on that British Menopause Society, do go on and look at they've got a lovely BMS website. They've got that lovely infographic about the prevalence of numbers of cases of breast cancer and all the various.
Yes. And
go on.
For those of you that were around or attended, we did have a session with Mr. Haitham Hamoda in October, and that's recorded, and that's also available on the charity's website page. I think we can get someone to post the link to that, but he talks quite extensively there about the risks around HRT and the myths. So it's definitely worth a watch if you have the time. So inequalities. Sorry,
Squeezy app. Someone put the Squeezy app on the chat. Well done. Thank you, Cherie. You're working hard here.
She's an angel, Sherry, absolute angel. Inequalities in women's health and ethnic minorities and self-advocacy. We still have problems with unconscious biases in the medical profession concerning ethnic minorities. What advice would you give to women from ethnic minorities to effectively advocate for themselves?
Well, again, think about what you want to talk about. Write it down. Take another pair of ears with you, somebody with you, and just refuse to take no for an answer. And again, just repeating back to people. So, are you saying then that you don't believe me, or you don't think that what I'm saying is important? You stay very calm throughout, but you repeat things back to people. It can often make them, oh my goodness, did I really say that?
Did I say that?
Yes, you did. And I think the other thing is that if you go onto the Wellbeing of Women website and go and look on the Women's Health Collective, if you are in a marginalised group and you would like to contribute to that collective, everybody is welcome. We have, I think it's 79 members now, or representatives from marginalised groups, and we've got physical disability, ethnic, religious, well, I mean, religion is not a disability, you know what I mean? They are sometimes marginalised groups. We've got people from all over the country, and they are all contributing to our Women's Collective and finding better ways to communicate and understand. So, for example, my interactions with women who are neurodiverse in that group have really helped me understand what I need to do to convey things. And it's changed, for example, we run the Women's Health Collective meetings when we have things, and the way we go about it, we find it's much, much better to be having small groups for discussion and to be posed, let's say, a list of questions, and people feel much safer talking about that in smaller groups rather than being, in a sort of theatre style lecture, having to put your hand up or stand up or say who you are or whatever. So lots of different ways of communicating, but please, if you feel that you have been marginalised and you are not, and you are being, what's the word I want? You've been, discriminated against.
Discriminated against, yeah.
Then please do come and see us at the Women's Health Collective, and we can put you in touch with other people who've had similar experiences and overcome with suggestions for how to do it. And for example, there are some South Asian groups who don't have a word for breast, or they don't have a word for menopause. So how can you possibly have these conversations, or how can they have conversations when they don't even know what the terminology is? So there's lots and lots of things that we can do to improve that. But as I say, the Wellbeing of Women site, I think, is a treasure trove of stuff. and we keep
Yes.
on pushing the boundaries and getting stuff up and running. So you're most welcome to join that.
And we, I mean, we do advocate the wellbeing of women, and we cascaded the pledge within the Department for Education, and 21% of the DFE have signed that pledge now individually. I know that the wellbeing of women is working on a tool on menopause to help organisations understand whether they're menopause friendly. And I know I have been speaking to Janet about it, but I just wondered, do you have an idea when that's going to be available to us? Because I think it's going to be just as useful as the period symptom checker, if not more.
I agree. And the Meno kit is coming out really soon. I think it's going to be in the spring. We had all sorts of pushback from various organisations, including the Department of Health and all those things. And I think we've managed to overcome all that now, because I can force things through by sheer weight of personality, but I actually want to take people with me, not feel that I've trodden all over them, because we'll have more followers if we get them to follow us, literally. And I think it's going to be coming through. We had enormous problems at the beginning trying to launch the period symptom checker. Well, not launching it. Launching it was easy. Developing it was complex. And we also had to do things like we had to go back to the Health Collective and ask them, were we asking the right questions? Because often these tools that you find on websites or on government, department websites and things like that, or they're often things that you or I, Audrey and Lesley, think that Kath or Sherry or Sadiq need. And actually what we have to do is spend a little bit more time and then actually talk to all of those people and find out what it is they want to have and to hear. And often the things are quite different. Now, it takes longer to co-produce, but one of my absolute bête noires is the people who think that they're co-producing, and actually they're giving you a sheet of paper to say, yes, she's seen that, and she says it's fine. That is not what co-production is. Co-production is actually finding out what the other people at the table really need and what they want, and also how they want it presented to them.
Yeah, we are looking forward to it. I'm looking forward to welcome Janet into talking to us about it when you're ready to launch it, because we are keen to use it in the civil service. Question on HRT licensing, but I think it's probably just as pertinent to prescribing. When will HRT licensing or prescribing reflect the real usage needs? And I think this is one of the big drives within the women's health strategy, so that off-license prescribing doesn't have to be a thing, and this would help with access to. We've talked about testosterone briefly, and the different licensing uses and years of expiration for the different uses of the marina coil, etc. And I think that there's an education piece again with the medical profession in terms of, prescribing, understanding.
I think it is, and I mean, so if I answer the question by going slightly tangentially, it took me 10 years to get the combined oral contraceptive pill over the counter. 10 years, and the evidence was very, very clear, and we always had people at the MHRA and all sorts of other groups of regulators and concerned individuals, GPs, primary care, secondary care specialists, all these people saying, oh yes, but what happens if a woman who's got high blood pressure and she takes estrogen and it'll be dangerous for her? And I can remember saying to June Rain when she was the head of the MHRA, but Dr. Rain, please understand that if you've got seriously malignant blood pressure, the far more dangerous thing than taking a hormone pill would be to get pregnant. And of course, that's exactly what happens to these women if they haven't got contraception. And there's going to be very little problem about women taking HRT. Eventually, we will get it over the counter in the same way that you can now get emergency contraception, not just over the counter, but you can get it free. And that's only happened last month, And it's a long, long time since we started. I started writing applications to the MHRA about how this was madness and we couldn't afford it, and we couldn't afford the fallout in terms of poor care and unplanned pregnancies and damaged women and women, getting pregnant, which is far, far more dangerous than ever taking a hormone pill. So it's an education piece. It's about, and I think it's also about patriarchy, isn't it? And infantilism. Sometimes we treat women as if they are little idiots, and that they can only do things that men tell them to do. Or bossy women like me tell them to do. But the thing is that they've got brains of their own. And as I started off the session saying, the reason why I feel so passionate about getting women to understand what they can do to help themselves, not to put the problem back on them, but to also help themselves on this life course journey, is because when you teach a woman or you show her what she can do to help herself, not only does she follow the advice, but she everybody else about it. So she's a fantastic megaphone for good practice. And that's what I think will be happening with HRT. It takes time, just as it's happened with all the other things. And if someone could find a way of getting onto TikTok or some of these young influencers platforms and explaining to girls that putting hormones in your body is not a bad thing, and they're being sold a rubbish line to use all these clever fertility tracking apps. And we've got so many young women coming in as well with unplanned pregnancies who've said, they're perfectly and able to follow advice, but they've been told by their generation, and by TikTok and influencers that it's bad to put hormones in your body. I mean, it's bad to do a lot of things in life, but you have to do these things in moderation and understand what relative risks are. I think it's something else. I think for women, because their bodies are complex, their hormones are complex, it's very difficult sometimes to explain to them about risk. They understand black and white, but relative risks are much more difficult, and to understand they're often very specific to that individual woman and her circumstances and what triggers her or what comforts her. So, and if you've got if you had a mum who died of undiagnosed or rampant breast cancer at an early age, of course you'll be frightened about all those things, but you need to then have someone explain what the relative risks are. And, if you've had a premature menopause at the age of 35, you are going to have early onset heart disease because you have lost 15 years worth of estrogen to protect your blood vessels and things ahead of your next door neighbour who's had normal estrogen levels. So everything is a relative risk. And I think trying to understand that can be complicated. It takes time and it takes patience from the people who, time and effort from the people who give you the information to describe it and allow you to access it in the way that you can best understand it.
I just had a vision of you, Lesley, on TikTok, sharing this as the UK Women's Health Ambassador, doing your own 60-second sound bites for young, impressionable females to listen to. How amazing would that be?
Yeah, but they don't want some old crab like me. They need some young, gorgeous person,
No, but what you're talking about, and that's the difference. You've got years of experience to talk from, so yeah, people do respect that. You touched on earlier Ozempic, Mounjaro, the kind of GLP-1s. So given that weight gain during menopause is more difficult to reduce, what are your thoughts on the weight loss injections that are available readily on the market these days?
Well, I mean, I never say no to anything because I'm always prepared to weigh up the pros and cons of things. So I think for many women, it has been life-changing because they've actually been able to see something happen. I know that the very recent studies, because I was talking on one of the webinars that we did for wellbeing of women, I think last week or the week before, and I was talking to a physician who knows a lot about these drugs. And he shared with me the fact that there have been now studies have been on women who discontinue, reach their target weight or get rid of a weight and discontinue, and how they can put weight on again. So I think it's important that you understand that if you're going to use those to get rid of weight that seemed to be impossible to shift in the past, and it can be quite transformational because it seems to take the noise out of the eating disorder, the eating problems that you've had. It just takes it away. You just don't think about that food stuff and you don't feel hungry. So that's great, but you need to also combine that with exercise, not just because you're losing muscle mass, as I mentioned earlier, but because
Mm-hmm.
you know you're going to have to keep this up at a later date, and you're going to have to keep your exercise, otherwise the weight's going to creep on again. And there's evidence now, if you lose weight before you embark on a pregnancy in order to make yourself healthier and fitter, that you actually put on more weight than you would do if you hadn't been on the Ozempic. So that is something that we're going to have to think about and refine going forward. So it's not problem free, but I think I would advise that you do it under the guidance of somebody who knows a lot about it, and you take their advice, and you make sure that you change your lifestyle as much as you change the injections, because you can't, it's not a quick fix. It's something that is going to help what seems like an impossible task become possible, but then you will have to do the other things that help you maintain that to achieve going forward.
And is there any research or indication of how these injections might interact with HRT, or is that still in the pipeline?
No, I don't think there's much evidence of that. And there are quite a lot of older women who are on now. So we would have had, certainly if we were going to have seriously concerning interactions, then I think they would have come out now. I think so anyway. Because there are quite a lot of women who are menopausal age and who will be on HRT who've been taking. Interestingly, if you're a younger person in the civil service, I don't know what the age span is on this call because I haven't seen all the faces, but you have to be a little bit careful. So my anaesthetist worries about some women who are taking it because they're just taking jabs all the time, and they are actually they keep taking these things because they want to remain the same weight or stay underweight. You have to remember that one of the ways they work is that they delay gastric emptying. So they delay the speed at which your stomach empties itself of the content so that you feel fuller for longer. And of course, if you're going to have an anesthetic, that can be dangerous. So what I always say to women, and I just sort of say it to the air as I'm talking them, if you're taking any drugs, particularly if you're taking any weight loss drugs, remember that you mustn't take them at least a week to 10 days before you come for the anesthetic.
Okay, great advice. This is a question that's come up before today. Can HRT cause hair loss? If the estrogen progesterone is too high or too low, how does it affect your hair?
Well, I don't think it does. What I just said when I was talking about iron deficiencies is that one of the things that really I often ask women when talking about the fact that I think they've got iron deficiency, and they say, well, how do you know? I said, because my hemoglobin's fine. I said, I know, but your iron stores are low. And then I say to them, does your hair fall out in the shower? And they look at me and say, how did you know? And I know because a lot of women have told me that, and I know because one of my daughters it happened to as well, and she kept complaining about the fact her hair was molting. And I said, Jenny, I think you've got iron deficiency. Oh, Mum, what do you know? Anyway, I was proven right, and she graciously said that she thought that was very wise advice, and she wished she'd listened to me before. But and you could all sorts of things, because if you can't take iron supplements, and lots of women can't because they get horrible gastrointestinal side effects, you can go and have an iron infusion, where you get almost a year's supply of oral iron into your arm, and it's transformational. I mean, these women walk in 3 months later and say, have you seen my hair? Isn't it wonderful? It's absolutely fabulous. And more important, about into the room as opposed to dragging themselves in and saying, I feel tired all the time.
How fantastic, though. I think there's an awful lot of women, certainly that I've spoken to, and we've had on the network talking about hair loss and linking it to menopause, but actually it's not. It's your iron stores. So I will definitely remember that one in the future. I know.
Remember as well that if you go into the menopause, because you're not bleeding anymore, doesn't mean your stores are going to go up. Because if you've bled them down to low and you're not changing your diet, or you're not absorbing it very well from your diet, you will continue having iron deficiency. So don't be tricked, because I've had GPs say, well, there's no point in doing that because she's not having periods anymore. Yeah, I know, but so I.
Well, let's hope that's going to change now with the recent ruling around more discussion about women's health and questions around menopause, etc. with GPs. I'm conscious we have a minute to go, and we could probably keep you all afternoon, Lesley and I.
I can do
Thoroughly.
another time.
Yes, absolutely. I will definitely hold you to that. But thank you so much for giving so freely of your time and for coming and talking to us about women's health in general. I've certainly learned a lot this afternoon on the call, and I'm sure a lot of others who have joined us have probably learned something too. So thanks everybody for joining. Lesley, if you could just hold on for 2 minutes. The recording, everybody, will be available on the Charity for Civil Servants website in the next few days. I will drop the link out to your network leads across the civil service. And thanks once again to the charity for hosting this call. And thanks to all of you who have joined today. It was great to see you.